Now, when we talk about barbiturates and benzo, they work very similarly with a little bit different. Now, if you see, barbiturates also works on the GABA, and this is also work on the GABA. Benzo, they're both working on the GABA. The difference, barbiturates increase the duration of chloride channel opening, folks, okay? So that means they open few times, but when they open, they keep it for a long time, okay? So that's a duration. When they do that, because GABA is an inhibitory neurotransmitter, decrease neuron firing, folks. Basically, the nerve cannot conduct the sensation, okay? That's the idea. So it's kind of increases the duration. Now we use it for sedative for anxiety, seizure, insomnia, induction of anesthesia and stuff, folks. Okay, people use that. The side effect is bad because it can cause respiratory and cardiovascular depression, folks. Okay, that's that. It can be fatal, CNS depressions. Okay, now overdose treatment is supportive because there's nothing to give antidote. Once it's overdosed, you just have to support, folks, okay? Now, we call it, I think we came across contraindicated in porphyria when we studied the heme synthesis. You cannot use this, it will make the porphyria worse. That's barbiturates. Now, let's take a look at benzo. Benzo is the same, but instead of duration, it increases the frequency of the channel opening. So barbiturates opens it, keep it for a long time, but whereas benzo, they open multiple times, but they don't keep it for a long time. So they increase the number, frequency, folks, okay? That's the idea. And also it decreases the REM sleep. Most have long half-life, except small ones, right? Like, for example, alprazolam, that's a Xanax, right? Very famous medication. What's the standard dose? 0.25 milligram, folks. It's a tiny pills that can knock people for 10 hours, okay? So that's Xanax. And then we have long-acting and stuff, okay? When do we use? Anxiety, panic disorder, spasticity, status epilepticus, eclampsia, detoxification, so many things you could use, folks, you know, night terror, sleepwalking, general anesthesia. There are so many things we could use it for, okay? So that's benzodiazepine. Now, adverse effect, dependence. If you take Xanax, the way you feel better, people like to take it again and again, especially anxiety, folks, okay? Now, additive DNS depression with alcohol and barbiturates. Less risk of respiratory depression and coma than barbiturates. So this is much better to give than the barbiturates. Also, overdose can be treated with flumazenil. So at least you have an antidote for this, whereas barbiturates don't have any antidote, folks. Okay, so that's important. It can precipitate seizure by causing acute benzodiazepine withdrawal if they take it and stop it suddenly, folks. Okay, so that's the idea. Now, that's benzodiazepine. So the barbiturates and benzodiazepine, know it well, folks. All right. If you see here, some insomnia therapy, folks. Okay, so that's a difficulty. Now, non-benzodiazepine, these are hypnotics. Zolpidem is a very famous medication. Okay. Now, they all work in a subtype of GABA receptors. Okay, so same side effect, look at this, ataxia, headache, confusion, and cause only modest day after psychomotor depression and few effect, folks, okay? These are much better than benzo and barbiturates, you know, that's the idea. All right, now, that's that. Then you have Sovereign, that's also receptor, orexin receptor antagonist, CNS depression, headache, abnormal sleep-related activities, those can happen. This is literally a melatonin, okay? So I don't think you will ever get a question because melatonin is to put you to sleep, but it doesn't maintain the sleep, folks, okay? That's the idea. I would only worry about zolpidem, even that, not too much. But this one, 100%. Triptans, that's for headache, right? Migraine and stuff, folks, okay? Now, look at this. This is so high yield, triptans can cause prinzmetal angina, folks. Okay, it causes prinzmetal angina. They're always checking this recently. That's why they keep adding this, folks. Careful. Okay. Now it induces vasoconstriction. That's why it's helping for headache. We talked about the other day, right? Caffeine does the same thing. So we cannot give this in people who has coronary vasospasm or even contraindicated with coronary artery disease. Even if they have atherosclerosis, you cannot give that sumatriptan and stuff, folks. All right, so that's that. Now we are getting into Parkinson's disease therapy. Okay, now when it comes to Parkinson's disease, right? What's the criteria you want to think about, the strategy? These people don't have dopamine. So you have to bring dopamine, right? But then you also have to make sure when we take a dopamine, we don't metabolize the dopamine peripherally. We want everything to go into the brain, okay? Not to the periphery. So we have to give multiple medications, folks. If you see here, first we give dopamine agonist. Okay, these are piracetamol, all this medication. We give that. We could also give ergot group bromocriptine. It's rarely used because it has cytotoxicity, folks. Those things, okay? Now, we could give dopamine agonist, and then we also give medicine to increase dopamine availability. That means amantadine, increase availability is there. And then we have increased L-DOPA availability, agent that prevents peripheral degradation. So we don't want to break down on the periphery, so it can go into the brain, folks, central nervous system. So that's the idea. Now, to talk about levodopa and carbidopa, I want to go to the next page. There's a separate section of carbidopa and levodopa. Let's get that, folks. Why do we give both together? It increases dopamine in the brain. Unlike dopamine, L-DOPA can cross blood-brain barrier and is converted to DOPA decarboxylase in the CNS to dopamine. And whereas carbidopa, which is a peripheral DOPA decarboxylase inhibitor, that cannot cross BBB. So it's given with this. They always ask a question on this, folks, okay? Which enzyme they block. So that's DOPA decarboxylase, okay? So that's important to know, folks. Now, of course, clinical use is Parkinson's disease. What happens if we give too much? They become technically schizophrenic. Because what's the problem with schizophrenia? Increased dopamine, isn't it, folks? So that's the idea. When Parkinson's disease people get treated, then they receive a little bit too much, they will start hallucinating. Okay, so that's the idea here, folks, okay? Remember that. So that's carbidopa and levodopa. Now let's go back. That's exactly what they're explaining in here, carbidopa and levodopa, how it works. There's something called entacapone and tolcapone. They also prevent peripheral L-DOPA degradation, okay? So that's also another way to treat that. Prevent dopamine breakdown. That agent acts centrally to inhibit breakdown of dopamine. So what are we trying to do? Increase the availability. If you stop the breaking down, you are keeping it more, folks, okay? Selegiline, all this medication block conversion of dopamine to DOPAC by inhibiting that, which is more commonly found in the brain than in the periphery. So that's the idea. So this medication increases the availability of that. Tolcapone, same thing, crosses blood-brain barrier and block the conversion of dopamine to that 3-MT. That's the idea. So they all increases the availability of dopamine. So you see, because it is very hard to treat, we have to put the patient on multiple medication and still we cannot. Now, if you see, there is no cure for Parkinson's disease at this point, unless they do some radiosurgery, but that's that. Some of the symptomatic treatment, curb excess cholinergic activity. We could give those antimuscarinic, which improves tremor and rigidity, right? So that means it improves, but it doesn't cure it, if you see. So that's kind of reduces the symptom, folks. That's Parkinson's disease. And again, I already put a star here, carbidopa, levodopa, 100% one question. Now let's take a look at it. Neurodegenerative disease therapy. Now we know there is no cure for any of those diseases, but you could slow down the progression, folks, okay? Alzheimer's disease. We have donazepam, rivastigmine, glutamine, those things, acetylcholinesterase inhibitor. That's the first line treatment for Alzheimer's, folks, okay? Now, again, they have side effect, contraindicated, In patient with cardiac conduction abnormalities and all these things, you cannot give. Memantine, it's a NMDA receptor antagonist, help prevent excitotoxicity mediated by calcium. So we could use that too. ALS, riluzole, there's no cure, and it can only increase as a survival. Like, it can prolong the symptoms a little bit. Huntington disease, tetrabenazine, inhibit those vascular monoamine transporter, decrease dopamine packing and releases, folks. So, because what's the problem? Can you guys remember the neurotransmitters involved in Huntington? Increase dopamine, decrease what? GABA and acetylcholine, isn't it, folks? Which one is unique? GABA, not acetylcholine. We did a question. So here, this is decreasing the dopamine, folks, okay? So that's doing that. All right, so that. Now let's go here. Some anesthetic medication, folks, okay? Now, this is a subspecialty, but there are some basic things that they ask you that you need to know. Most of the anesthesia drugs must be lipid soluble, so it can easily go into blood-brain barrier, okay? Now, let's learn what is this minimum alveolar concentration. So anytime we put a patient on anesthesia, we give the minimum dose required then, okay? Because you don't want to give a higher dose because that becomes very dangerous to patient, right? So the minimum alveolar concentration means it required to prevent 50% of the subject from moving in response to pain. That's all it is. So, if I were to explain in a layman word, let's say we have a patient that's going for a surgery. We give a very minimum amount of anesthesia, so they go into anesthesia. But sometimes you hear, notice it when you do rotation, the minute surgeon started making an incision, these patients move or they kind of scream a little bit, which means they could still feel it. Does that make sense, folks? Then what they do quickly, anesthesiologists will increase the dose a little bit more than that. Then they won't scream. So why do we do that? Instead of giving a high dose right away, we start with the minimum what they require, because some people are okay with it. It's about each patient's pain tolerance. Does that make sense, folks? So that is a protocol to start anesthesia with the minimum what they need. Okay, we don't want to give them high dose right away. So that's what it is basically, folks. Okay, now example here, nitrous oxide has decreased blood and lipid solubility and thus has a fast induction and low potency. So that means it does work fast, but it's not too strong. Halothane has increased lipid and blood solubility, high potency, slow induction. It takes a little more time, but it's very strong, which means this can get more toxic effect, more toxicity, folks, okay, because it's high potency. These are general anesthesia principles, folks, okay. Now, let's talk about inhaled anesthetic. There are different types of anesthetic, right? IV, local, and then inhale. This is the inhale one. Nobody knows the mechanism how inhaled medication works. The idea here, it can give myocardial depression, respiratory depression. Look at that. All these things can happen. So they have to be very careful. That's why if you see most of the time for surgeries, they try to avoid general anesthesia, folks. They always go with the minimum required one because of the side effect. Hepatotoxic, nephrotoxicity. Look at this, 100% malignant hyperthermia. We talked about this where? In psychiatry. Remember that, folks? Malignant hyperthermia. Neuroleptic malignant syndrome, same thing, folks, okay? Dantrolene is this treatment for that. Patient never wake up next day with a high fever, hyperthermia, and muscle rigidity. Remember that, folks? That's the idea here, okay? So that's, again, a high-yield topic. Then you have intravenous anesthetic. These are IV anesthetics, okay? Now, thiopentol, facilitate GABA. Look at that. Everything is working on the GABA here, folks, okay? All those three works on a GABA. Induction, anesthesia induction for short surgical procedures like, colonoscopy, little surgeries, they use these kind of medication, folks. Procedural sedation, endoscopy, look at that, those things they do. Everybody knows what is propofol. Everybody knows how Michael Jackson died, right? So this is what he used to take it every day to sleep. Can you believe that? So, he will take this, and that's how he sleeps in the house. Now, how did he die? It causes respiratory depression and also myocardial infarction. That's exactly how he died. So, I read whatever is online, that autopsy report and the whole investigation. He had a doctor. That doctor was getting paid about $150,000 to $200,000 a month just to prescribe propofol. And he used to send a text message. He needs to sleep. He needs milk. Why do we call the word milk? Propofol is white color. It exactly looks like milk. So that's a message he will text. And then they give that propofol. He will come and give it in the house. Now, how did he die? He didn't die because of that medication exactly. He died because of the doctor. You guys know what exactly happened, right? So when he was taking propofol, he started going a little bit of myocardial arrest, okay? So, but the doctor didn't want to call the ambulance right away. He waited a few minutes to clear all those evidence, because you are not supposed to prescribe that medication in the house, right? So he took a few minutes to take the medication bottle and everything to hide. And after hiding, then he called the ambulance. So when the time ambulance came, it was late. If he would have called right away, he would have been safe, maybe. Okay, we don't know that, but he didn't call it. So they found that he used to hide that propofol bottle inside the saline line, and that's how it used to go in a drip. That's crazy to take that to sleep, right? So that's the idea. So he spent more than $1 million a year just for propofol. That's a life you live, right? So that's that, folks. Okay, propofol. Right. So that's look at this ICU sedation. Now, one of the reason he got in trouble, I mean, he got so many charges, that doctor, right? One of the reason they charge, listen, can you prescribe propofol? Yes, you can. But the only thing is you cannot prescribe to use outside the hospital. Does that make sense, folks? He could have been completely okay if Michael Jackson were to go to the hospital to sleep every day. Does that make sense, folks? So one of the charge was to prescribe a medication that cannot be used outside the hospital. That's one of the charge, folks, okay? So he had many charges, but this is one of them. So that's propofol. Next one, ketamine. That's another, this is anesthesia medication, folks. So that's IV antibiotic, anesthetic medication, folks, okay? So those are those. Now, then we have local anesthetics. So these are injection, like before the surgery, they block that particular. This is the most safest one because you're only blocking that particular area, folks, okay? Now you have different types. The mechanism is to block neurotransmission via this voltage-gated sodium channel. Voltage-gated sodium channel, folks. If you recall cardiac pharmacology, there is a blocking of voltage-gated sodium channels. Type 1 antiarrhythmic, remember that? Isn't it? Type 1B is lidocaine, was an example. It's the same thing, folks, here, okay? We use lidocaine for that, right? Now, in this section, you want to highlight this. 100% important, this one, because they ask this in the order of loss, folks, okay, whenever you are taking this medication. So whenever they block lidocaine, local blocking, this is how we lose it, folks. First, we lose the pain, then temperature, then touch, then pressure. So I don't know if you guys ever had a local lidocaine. Sometimes when you take a lidocaine, you don't feel the pain when they cut, but you feel a pressure. You could feel that something is pushing. It doesn't hurt, but you still feel it. Sometimes people say, oh, I feel it's very warm, right? Because they feel the temperature of it. Key, folks, as long as you don't feel pain, everything else is good. Does that make sense, folks? So that's lidocaine, right? So that's the idea. Now, this, sometimes what they do, they give this in a different order. So you have to know the right order. Pain, temperature, touch, pressure. That's how you lose it. Okay, so that's the idea, folks. Now, we use this for minor surgical procedures and stuff, but side effect is very, very minimum, folks, because you are blocking that particular area, right? So that's the mechanism, folks, okay, here for that. Now, next, neuromuscular blocking drugs, muscle paralysis in surgery, or mechanical ventilation. Now remember, folks, before we intubate a patient on a ventilator, you need to shut them down first, because the machine is going to take over. So we have to use this medication before they go into the ventilation. You know, that's why some people freaked out during COVID. If I go into ventilator, I will never wake up. Is because you have to shut them off before you do that. And which is technically, you know, any complication can happen, right? We put them on ventilator thinking we could wake them up. I mean, it happens 99% of the time, but that 1% always they don't wake up. Okay. So we shut them down. We use a succinylcholine. It's a strong NM-nicotinic receptor agonist, produces sustained depolarization and prevent muscle contraction. Okay, so when we put a patient on ventilator, basically we do not want your body to function. We want the machine to take over, so that gives a time to heal. That's the idea. Okay, now reversal of blockade. Phase 1, the prolonged depolarization, there is no antidote. There is no antidote. Okay, but phase 2, the repolarized but not blocked, that's maybe reversed with some cholinesterase inhibitors. Okay, I don't think they're going to ask you this much deep of anesthesia question on step 1, but just to know the side effect: hypercalcemia, hyperkalemia, malignant hypothermia. You see, malignant hypothermia, I keep repeating, folks, so that should tell you that you should know everything about it. Okay, so that's the idea here. And then we have a non-depolarizing muscular blocking drugs. Okay, so these are those medication, again, receptor antagonist, nicotinic receptor antagonist. The only thing is you could get the reversal of blockade with this medication, folks. Okay, so that's neuromuscular blocking agent, folks. Okay, now continue. In this page, super important is opioid. But before the opioid, let's quickly talk about this muscle relaxants. These are most commonly prescribed when people have a back strain or any neck strain. It's a muscle spasm, right? If you see baclofen, cyclobenzaprine, these are simply used for muscle spasms, folks. Okay, muscle spasm. And dantrolone, what did we say? Clinical use, malignant hypothermia. You see, this is a third time that word is repeating on this subject itself. Okay, so that's that. Now, talking about opioids, this is important. So opioid medication, these are pain medication. They work on the opioid receptor, more receptors, the other receptors, to modulate synaptic transmissions. Now, what I want you to understand, when people take opioid for pain, is it curing the pain or is it blocking the pain you feel? It's basically blocking the pain you feel. So the pain is still in the body. You are not just feeling it. That's why when the medication weans off after a few hours, the pain comes back. So the right word is not the pain comes back. You started feeling the pain again. Is that clear, folks? But when you tell, oh, the pain went away, it comes back. No, the pain was always there. Now it's started feeling, folks. How does it work? It closes the presynaptic calcium channel and open postsynaptic potassium. So basically what you are trying to do, you are hyperpolarizing the cells, hyperpolarizing. Once you hyperpolarize, there is no action potential. Nothing can be transmitted. Is everybody clear, folks? So the signal cannot be transmitted. Decreased synaptic transmission, folks. Okay. I just saw the text message on the chat group about the barbiturates and benzodiazepine. All right. Now, full agonist. Okay. Full agonist, these are morphine, heroin, all this medication, methadone, codeine, all these things, right? So partial agonist is buprenorphine. What did we say about partial agonist? You only feel half, 50%. That's the idea, folks. Okay. Then you have antagonist. This is important. Naloxone, naltrexone, methyl naltrexone, these are all antagonists, folks. Now, clinical use, moderate to severe or refractory pain, diarrhea, some other pulmonary edema maintenance programs and stuff, folks. Okay. Now, we talked about a little bit in the psychiatry, but one of the things that you need to know, side effect, nausea, vomiting, all this, okay? That sphincter of OD spasm, okay, I just highlight it. Sometime I've seen this question here and there. After a surgery, patient all of a sudden develops sphincter of OD spasm. That's because of pain medication they used after it. Why it is the problem? If the sphincter of OD is spasmodic, can the bile come into GI tract? It cannot. So all the bile backs up and block dilated common bile duct and all these things, folks, okay? Now, another thing that people, they always check this line. No matter what, you never develop tolerance to meiosis and constipation. So what does that mean? Tolerance doesn't develop. Some tolerance, right? Like for example, there are some side effects. I'll give you a good example. Some people who drinks a high dose of caffeine, they get palpitation, isn't it, folks? So if you drink Starbucks coffee, like some people cannot handle the dark pike because it has such a high caffeine. They say after drinking, they get palpitation. Same thing with the Red Bull. After drinking, you get palpitation. But if you keep drinking, what happens? Eventually, it doesn't work anymore. So you don't have palpitation, nothing. So you developed a tolerance. Is that clear, folks? But when it comes to pain medication, no matter how long you take, you never develop tolerance to meiosis and constipation. That means every time you take it, you will have these symptoms. Is that clear, folks? Nobody can tell, oh, I took pain medication chronically, now I'm used to it, I don't have constipation anymore. No, that's wrong. They will always get constipation, even if they use for 10 years. Is that clear, folks? So they used to ask on NBME, what are the two symptoms they never develop tolerance to? That's meiosis and constipation, folks. Is everybody clear? So they will never develop, okay? Every time they take them pain medication, they will have those two symptoms. No way to get used to it, okay? That's the idea. So that's opioids. Now, tramadol. Tramadol is also very weak opioid agonist. Also inhibit the reuptake of norepinephrine and serotonin. People use it for chronic pain. What's the difference? It is not addictive, folks, okay? People don't get addicted to that medication because this is not like 100% opioid. When you take tramadol, the pain is a little bit there, but it feels better. You could still continue with the daily activity, so people don't get it. Similar to opioid, decreased seizure threshold and serotonin syndrome, folks, okay? That's the idea. So that's good for tramadol, okay? So tramadol is the best one to use without addiction. Now, there's some mixed agonist and antagonist opioid, right? So what does that mean? If you see that pentoxacaine is opioid receptor agonist and opioid receptor weak antagonist, it's basically think it works 50%. That's the best way to think, okay? So it has both effect. Analgesia for moderate to severe pain. So we give this, they feel better, but at the same time, they don't feel to a point that is completely gone, right? So it makes them feel better, no addiction, folks. That can cause opioid withdrawal symptom if the patient is also taking full opioid agonist. They cannot take both because this is going to interact with the other one, folks, okay? Now, butorphanol, it's the same thing, severe pain, causes less respiratory depression than full opioid agonist, folks, okay? So it is something that given to people if you know that they are taking it longer period, at the same time, you don't want them to become addicted, okay? That's the idea. When somebody's in a severe pain, they do that. Now, this is another one, folks. It says, capsaicin, naturally found in hot pepper, excessive stimulation and desensitization of those fibers, decrease substance P release, decrease pain. So people who take those, they have a decreased pain sensation, and they could clinically use for musculoskeletal and some neuropathic pains and stuff. Okay, so that's that. Now the last part I believe we have here, glaucoma therapy. So if you remember glaucoma, there's two types, open angle and closed angle. We say anything that causes meiosis will cause closed angle. Is everybody clear, folks? All right. Now look at here. So your strategy for glaucoma is decrease IOP by, you could do decrease production or increase the drainage. Okay, so these are the two things you could do. Now there is a beta blocker. Okay, it decreases aqueous humor synthesis, no pupillary or vision changes, so that's safe to give in closed angle folks. Now if you see the other one, alpha agonist, okay, these medications, it can cause mydriasis highlighted, so we cannot use in close angle glaucoma. So alpha agonist is contraindicated in open and closed angle glaucoma, so you have to be careful which one the patient has. Okay, so alpha agonist cannot be used, whereas diuretics like azithromycin is very safe because it doesn't affect the pupillary or vision changes. All it does is decrease the synthesis, so you are not increasing the pressure, folks. Okay, next, prostaglandins. Now, what does prostaglandin do? Increase outflow of aqueous humor via decreased resistance of flow through the pathway. Only thing it can do, darkens the color of iris. So it increases the color, but that's okay, but it's safe. Last one, cholinomimetics. It's a direct. Pilocarpine, carbachol, indirect also you have it there. Increases outflow of aqueous humor. Okay. Now, meiosis, contraction of the pupillary sphincter muscles and cyclospasm. So can you use this to close angle? You can, okay? Because remember, in the dark, pupillary dilation, does that make sense, folks? So that's not the problem. So you could use it here, okay? Use pilocarpine in acute angle close glaucoma, very effective in opening those channel folks, okay? So that's that. Now, I don't think you can, you might have some function, but in reality, in the step one exam, I don't think you will get any of those, but 100%. One question in opioid and tramadol also, folks, okay? They will, because that's the biggest problem in the United States. And they will ask you, and muscle spasms here, some general terminology what we studied, but definitely Parkinson's therapy. Like, if I'm studying this, I would focus more on Parkinson's, barbiturates, benzodiazepine, and triptans. These are the questions that come frequently, right? That's what I'm studying smart. Don't try to memorize every little page. It's not going to happen. Now the last one. Let's go to this page. Go to the page. I like that. Ethosuximide. It is a drug of choice for absent seizure folks. Okay. Now one of the side effects also is SGS. What is that? Stevens-Johnson syndrome. What is that? Less than 30% of the skin involvement. Remember that? All right. Sometimes I see that. And I already mentioned carbamazepine, first line for trigeminal neuralgia the other day. When people have trigeminal neuralgia, we use that medication.
Doctor, SGS is just a less serious toxic epidermal necrolysis.
Less than 30% SGS, more than 30% toxic epidermal necrolysis.
Okay, thank you.
Now, in case ethosuximide is not an option, valproic acid also can be used as well for absence seizure. Okay. That's what. Thank you. Now, just to kind of over here, phenytoin, right? It just blocks sodium channel. Zero kinase. Okay. Now, if you see phenytoin, these are cytochrome P450 induction. They give you so much of side effects. Okay. Enlarged gums, yellow skin. You cannot use it during pregnancy, osteopenia, all those things with a little bit of phenytoin. I remember.
Dr. Roy, so which one is safe for pregnancy? out of all these,
For what purpose?
if seizure-wise,
Seizure-wise,
pregnancy,
now you have to get usually use benzos, but you have to be one of those benzodiazepines to be more safe than garbage. What else is there? Gabapentin, right? Just to know it's used for peripheral neuropathy. Gabapentin is supposed to nerve cells. It's just commonly prescribed. Okay, so gabapentin, especially people who have peripheral neuropathy, due to diabetes, anybody who has peripheral neuropathy, they use this medication. That's pretty much how it is. That's it. So that's your neurologists.
Dr. How would we explain neurologic in question?
So they would say the patient comes with the shooting pain on the face. It's like shooting pain on the bottom of the fashion. And that's basically what they have. Like they would say no infections and all of these things happen. When you read it, you know it's like trigeminal. Yeah. All right. So that's your neurologics. Yeah. Now brain stimulation. I repeat that's the most important here to learn because it's not difficult to see. If you spend time, no, it's a lesion. If you know, let's call that medial medial temporal around the tracks. Corticospinal and dorsal column, folks. So how do you differentiate medulla from pons? Medulla and medial wall, pons is 6. That's it. 6. Less than a minute to recall. So all you have to do is, my suggestion is to draw this diagram, folks. Make your own diagram, and if you write it nicely, you will never forget. Okay, because when I write it goes into your brain. Okay, so that is for neurology. Any question for me? No question. I've had to use this. We have extra time today to talk to people one-on-one. So what I'm going to do, everybody wait on the wait line, and if you want to take a break, just come to my mic. I'm going to talk to you, change a little bit. Okay. So utilize the time. So